Welcome to Thanatology Themes. I'm Carolyn, your host, therapist, and thanatologist. So I'm really excited today. I'm going to refer to my paper, which has my logo and all my notes on it. So we're here with Annie Gross. I am going to read your bio. She is a geriatric care manager and a writer, but I'm going to give the details. Is that okay?
Yes, ma'am.
Annie Gross is a geriatric care manager, a professional specializing in creative problem solving and advocacy to help older adults stay in their home or remain as independent as possible. She specializes in medical settings, physician visits, hospitals, all sites of care, as well as helping her clients and their families navigate end-of-life decisions and care, which is something we talk about a lot. She is known for her hands-on, passionate dedication to her clients and for facilitating communication for them with all providers, which is a big job, I know. Annie is also a professional editor and published writer. Her column, A Daughter's Journal, ran for 2 years in Caring for the Ages and captured 2 Apex Awards. She lives in New York City, where she served on the board Aging in New York. And we'll talk more about the writing because it was a 13-part series, but so thank you for being here.
My pleasure. Thanks for having me.
So there's a couple things I might jump around a little because you're so interesting and you have so many, and I want to try to cover everything. But I also think you told me you have a master's in gerontology.
I do. Yes. I have a master's in gerontology from the University of Southern California, from the Leonard Davis School of Gerontology. Yeah, it's a master's of arts in gerontology, not science, though.
Oh, okay. I just think that's really, I have a feeling that's a newer, I mean, maybe in the past 10, 15 years, but I feel like that's maybe a newer part of our field.
Yes, I would say so. Yes, the Master of Arts is. Yes.
So I just think that's a really interesting, I want to add that in. There's, because I feel like now there's so many different things we can do to kind of educate and learn different pieces.
Absolutely.
So do you want to start? I thought maybe we would start with your writing.
Okay.
So will you tell us a little bit about, and the Apex Award sounds cool. That's neat. You won an award.
Well, actually, the publication won the award.
Oh, the publication.
Yes, the Apex Awards are awarded to the publication.
Wow. Okay. Well, tell me a little bit about, so it was a 13-part series, right?
It was, yes.
Okay. Yeah.
So my approach to the world has always been as a writer. And when my mother took sick down in Florida, so the first thing I want to do is write about it, or at least record and think about it. It's my way of processing. And so the first one was I went down there and I was so conflicted. I live in New York City. She lived in St. Petersburg, Florida. And I felt like there wasn't enough time to be together and I had to go back to my life. And it just was really painful to me. And I once said something to her about it and she said, Annie, you're not going to move down here and I'm not going to move up there. So I thought, right, that's the bottom line. But so I started writing about it. She got this awful scourge of a disease called Clostridium difficile, which is a spore-based disease of the GI tract. Yeah. And it's very hard to eradicate, and nursing homes are terrified of it. It's got a characteristic terrible odor. Are you familiar with it? You're shaking your head. Yeah.
I want to jump in. So when you first said that, I'm like, what is that? And then I go, C. diff.
C.
Right?
diff. Yeah.
That's the word, at least the social workers, we were told C. diff. Oh my gosh, someone has C. diff. I do. Yeah. So that, yeah. And it is true. It has a terrible odor. Oh.
Terrible. Okay. Terrible.
Yeah.
So my mom was home and she got C. diff. She didn't know what it was, obviously, but that was what sent me down there to her. And I just was beside myself. I don't know any other way to describe it. So I started taking notes about what I was thinking and feeling. And I thought, I'm not the only one going through this. And I realized that the theme of that first one really was the loneliness of the long distance caregiver. That's the name I gave that column. So it, like any piece of writing or any creative anything, it came together very slowly. Each thing built on the other. My experience with a mom, my notes, and then I somehow found caring for the ages. I'm not sure how, but I said, hey, I'm going through this. Would you like to see something? So they said yes. So that's how it all started. So I called it a daughter's journal, and there we were, off to the races.
Mhm.
Yeah.
It's so important. One of the things, you didn't use the word guilt, but I've worked with a lot of clients who I think would say, I was guilty. I felt guilty. I wanted to go, and I don't know, anything in that you want to add?
Yeah, it's definitely in there. Guilt, it really, maybe I just was kidding myself, but I wasn't in touch with feeling guilty. I was just in touch with feeling terrible and wishing I could be with her. On the other hand, there's the issues between mothers and daughters, which is complicated. And so I didn't ever really spend a whole lot of time down there. I'd go down frequently and stay briefly, as opposed to going for a week at a time. And I had a whole big life back here as a communications person and a wife. And yeah, so no, I'd have to say I'm happy to pat myself on the back and say that guilt wasn't really part of it. I
Mhm.
just felt conflicted. Yeah.
Yeah, yeah. So a lot of different feelings maybe in there. And sure, like you said, your relationship with your mom is like conflicted and all different things. And then we bring maybe some things from the past, or yeah, yeah. And the long distance, I think, is really tough. Um, so this sounds like a really, and what was the name of I know A Daughter's Goodbye was the first.
Final.
Oh,
Uh,
final.
It was the final one. Yeah. So it was a 2-year column, it turned out to be. So the first one was the loneliness of the long distance caregiver. And then the last one was A Daughter's Goodbye. And that we can talk about that.
Mm. I apologize. I had them reversed, but it makes sense, of course. A daughter's right. So you were caring for her, and then the
2 years.
goodbye.
Yeah.
So now, oh, so she got diagnosed with C. diff, and then it was a 2-year journey then from there.
It was. So she went to the skilled nursing facility, theoretically as rehab. And then her function, as you can imagine, declined rapidly. And she ended up moving there. And that was very traumatic for her, for me. But she was a trooper, I have to say. My cool mom was a real trooper. And but so that was the beginning. And yeah, that her illness took her there to do rehab, and then she ended up having to stay there. Yeah.
Will you give us a sense of some of the other articles that you wrote in is article the right word?
Yes. Yeah. Yes.
Columns?
Uh-huh.
Yeah.
Yeah. So the other ones were things like an outside visit to the GI doctor. It was I don't know if you know about skilled nursing facilities, but it's a big deal to take a resident off site.
Yeah.
So we had an outside visit to a GI doctor. The hallmark of that one, Carolyn, was that she had to give a history, and her self-report history was really just nowhere close to the reality. So and it's very much what I deal with as a geriatric care manager too, that tension between making sure that the person has individual freedom. I don't infantilize anybody, or I always try not to infantilize anybody. And yet knowing that the doctor needed to know what was true as opposed to the way her self-report was. So I I I I did things like said, well, mom, I remember it differently. I remember thus and such, and hoping the doctor would pick up on that. And then sometimes she'd say, oh yeah, or else she'd say, sometimes she'd disagree. But I think it gave the clinician a much better sense of what was possible as opposed to the self-report, which was, I felt fine, and
Mm.
nothing was,
I
nothing was.
I mean, I think you bring up a really good point, and I know that caregivers have also reported to me when it comes to Alzheimer's or dementia, sometimes people can, their loved one, who we often call a patient, can answer certain questions, and so the clinician doesn't quite get the sense, but the family's like, "No, no, no, she couldn't remember, my niece's whatever, daughter, name, whatever," right? And so it feels like they know how to answer the question in a certain way or cover up or sneak around it, right?
Yes.
Um, uh, and then it's worrisome for the family.
It is. And I dealt with that with my clients all the time when one client that I cared for 4 years, she and her husband, they had a long-term care policy. So the policy, the company had to make an on-site visit. And my poor client, she had dropped head syndrome. She really couldn't walk. She was quite frail. She needed a walker and she crept along. Well, when the company came along, all she wanted to do was shine and show them
Mhm.
what an A student she was. And so whenever they'd ask her a question, do you have trouble? Oh no, I don't have any trouble. So, but in that case, it was not an issue because they actually could lay eyes on her and see how much trouble she had walking and what she needed help with, those kinds of deficits. With my mom, though, with the clinician, the self-report of the history, that was really problematic. So, and again, I tried to give her dignity at the same time telegraphing to the clinician that no, in fact, here's a more accurate
Mhm.
picture.
And you bring up another really good point, and I know in hospice, there came a point, of course, we want to, honor people's, autonomy,
Yeah.
and of course, when they have capacity, and I think it was really hard for a lot of our families when that started to change, especially if it's you're taking care of your mother or you're taking care of your spouse,
Yes.
or partner, and I remember we would sometimes have to give people permission to say, you actually have to kind of step in now. The person isn't, certainly we had some clients who would have like mets to the brain or something.
Yeah.
And I think we had to kind of role model or let the family know but it's a hard balance, right?
It
Like
is
you say,
hard.
where is that balance?
Absolutely. And you know what, Carolyn, I find that that really is the essence of being a geriatric care manager, is finding that very precarious balance between not just the autonomy of the person, clearly, and my motto comes out of disability care, the disability care model, which is nothing about me without me.
Mm,
I always want to
yeah,
involve my clients, so that can bump up against the adult children
yeah,
who, for whatever reason,
yeah.
want to take um, they want to take the reins on things. They want to make a decision that's one way. And I feel that that's not in my client. And my client is always the older adult, no matter who's paying the bill. So you know just what I'm talking about, that tension.
It's really hard, and I know I've, sat with, older adults, who are, 80s or whatever, and, their kid who, I mean, is 60 or whatever, but it's like, "You're my kid, I'm the parent," and then they're like, "My kid thinks they know better." Of course, the kid is like, a big lawyer and, but it's a really hard balance of, like you said, the kid is the mom sees the kid as the kid, but, I totally hear you, and of course, then it's like, where's the place of like safety? And of course, we have to manage all of these kinds of things, right?
We do. And in my case, as a geriatric care manager, sometimes it'll be the adult child paying the bill,
Hmm.
or more often it's the older adult and it will come out. But of course, the adult child is thinking, this is my inheritance, where's it going?
Yeah.
So that's a big tension too. What's affordable for the older adult? And yeah, that has a lot of issues involved, as you can imagine.
Hmm.
Yeah.
So this is all woven together. We were talking about
Right.
your writing, which I know is personal, but it is also very much connected to the work that you do as well.
Absolutely. Yes.
Yeah.
Sorry, I was talking about some of the columns you were asking. Sorry.
Hmm.
So one was an outside visit to the GI doctor. Another one was called Saturday Night Fever in the nursing home.
Hmm.
And that's kind of a corollary in that my mom was very sick, and there are no medical people
Mhm.
on site. I mean, at least not where she was.
Yeah, yeah.
And fortunately I was there. And again, I live in New York City and she lived down in St. Pete, so I wasn't always there. So, when she had a fever, right then the only thing to do was to call the medical director, which, the older adult never wants to call the doctor.
Mhm.
It's never that serious. And I didn't want to bother the doctor either. On the other hand, of course, I wanted my mom to be cared for. So, again, tension.
Mhm.
I mean,
Absolutely. I mean, speaking as a medical person, that's their job. You should bother them. I
I
don't know.
know,
That's what I
yeah, no, I believe me, I make sure that I feel that way. Yeah.
But yeah, yeah, I hear you. So that tension of, right, mom, oh, don't bother them. And then you're, yeah, yeah. Any of the other columns that you wrote that you want to share, you feel would be important to talk about?
I think you showcased the first and the last one. I think those are the most important in terms of framing the trajectory of what happened when my mom got very ill with the C. diff. And
Mhm.
then the last one is up close and personal on her actual dying process, and we can talk about in a bit. But the only other one was I wrote one that I called The Play's the Thing,
Mm.
and another one called The Triple Stealth Mission. But The
Mhm.
Play's the Thing, I felt like I was playing a role when I went down to the skilled nursing facility where my mom was. I walked in and I felt like I was youth itself, and I was walking in, even though I was, I don't know, in my 50s or something. But it felt to me like very much like the stage set for a play. And
Mhm.
so my mom had one role, and she had always been the queen in her life. And here I was, not the queen, but having to kind of play the central role. So maybe it was just an easier way for me to process it, to think of it theatrically. But I kind of think of everything theatrically. But so
Mm.
yeah, that's another one.
That's really interesting because in a couple weeks, I'm going to be interviewing a drama therapist.
Oh,
Yeah, she works only with children and sometimes very young children. But it's really interesting because she does the same thing a lot with kids. Yeah, it's really interesting.
I can't believe you're saying that, because I was on the board for years and years of Creative Alternatives of New York, and it was drama therapy.
Mhm.
So maybe that's probably where I got my whole theatrical bent, is that because you enroll as somebody, it's not, you don't put on a play, but
Mhm.
as you'll see when you talk with this person, drama therapy is helping the person to not be who they are, or if they choose not to be. But so we worked with people who endured trauma.
Mhm.
So rather than having to be the victim all the time, they could enroll as the queen or the king or what. Anyway, so I know what you're talking about. And yes,
Mhm.
it's a very good way of coping.
Yeah, so I'm hearing that's really a strengths-based perspective or strengths-based way to approach it, right? Yeah. And also you really touched upon, I know a lot of this is about our role, right? My role as a daughter, and what does that mean? Or my role with my mom. And then, that shift is like, and I bet that's a lot of what you might have to work with. It's like, whoa, where, right?
Absolutely. And, thank God for supervision,
Mhm.
because especially with my couple who I adored, they lived 5 blocks north of me. They were, they could have been my mom and dad. So I was really struggling frequently to remind myself, okay, you're not their daughter. You're not their daughter.
Hmm.
Um, Especially, when things got rough and when one or both of them acted out against me, and I had to really work hard not to take it personally. And, any professional struggles with the role of, personal and professional.
Yeah, that boundary is really, really important, right? But it's, we have to really be aware of it. Yeah.
Yeah.
Do you mind sharing a little bit about your last column and your mom's end of life process, or how you processed it?
Yes, thank you for asking. I was reading it over last night, and it's so sad.
Mm.
Um, it's, as I said, it's the lens is up close on my mother's dying process. And she had been in a tremendous amount of pain from they had to remove a growth on her leg. And I watched her suffer, and I couldn't stand seeing her suffer. And I went to the nurse and I said, isn't there anything we can do? And the nurse came back with me and she said, oh yes, she's in too much pain. And she said, I'm going to call the doctor. Well, the net was they ended up prescribing Roxanol, a narcotic for her to control the pain. And that's when the guilt came in, because I thought, oh my God, I precipitated her death by calling and asking for this. And she was saying, no, 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 I don't need it. But what, I didn't understand the point of her suffering. So that was the beginning of it, when asking them for some help and them bringing in the Roxanol and excuse me. And since then, every friend and every professional has assured me that I absolutely did the right thing. But yep, that's where the guilt comes in, because I think, really, should I have done it? So that's where it started, is controlling her pain. And then clearly she was descending into the dying process. That became clear to me, as much as I wanted to deny it and as much as she wanted to deny it. And she started to say things like, oh, I have my whole life ahead of me. That really stuck out to me last night. I thought, oh boy, I know that feeling. We get to a certain age and we think, but I have my whole life ahead of me. Well, no. And she started to say things like, she would talk to my dad, who died, excuse me, 5 years prior. She would say, oh, but I'm just a little girl. And then she started talking about going on a trip. And of course, I know from my training that that's very much in keeping. Well, and of course, as a hospice person, that's very much in keeping with the dying process. So at the time, I really wasn't trained as a geriatric care manager, but my instinct as a person and as a daughter, and I think especially as a writer, was to just go with her on the flight. So on the flight of fancy, that is. So she started talking about, I'm going to take my sweaters and I'm going to take a light blue and a dark blue. And I'm like, oh, do you think you want, just went along with it. Oh, do you think you want both of them? And she said, yes. And I said, okay, that's good. And she said, well, I'm going to go on the bus and I'm going to go upstairs, all again, images that come from the dying process. And I'm like, okay, can I come with you? And she said, oh, yes. And so all of this is written in the column. I sat at her bedside and I typed it all in. And at one point, I didn't put this in the column, but at one point she looked at me, she goes, what are you doing? Stop writing everything down. And I literally couldn't stop myself, because I knew it was her dying process and it was so rich, and the utterances were just, just so rich. So I did write it all down, I must say. And she, she wasn't really aware. I think that was one moment of awareness, hyper awareness. But after that, she didn't seem to mind that I was writing down all her utterances. So I'm really glad I did, but I must say it's very hard to read again, because it brings it back very clearly.
Yeah. And what you're saying, that's all part of the dying process. I mean, certainly the trip, but it is true when people get towards imminently dying, or they often go back to their primary family.
Yes.
And I've worked here in Brooklyn with a lot of clients who their primary language may have been Spanish or Russian or whatever, and a lot of times their kids were born here and were like, I don't even know what she's saying. The kids were like, she's lived here 50 years or whatever, but she'll, they go back to this primary, like you said, or sometimes they'll think their daughter's their sister, or, yeah. And like you said, talking to your dad, we see that also, right? To people who've gone before them,
Yeah.
I do want to go back and say, because so you had said a lot of, medical professionals, when you were saying your mom got the Roxanol, and we do morphine,
Yeah.
I always say when people came onto hospice, I say to the family and to the patient, our philosophy is that people shouldn't have to suffer.
Yeah,
You're in charge. It's your choice. You can do what you want, but we feel people should not have to suffer. And we really want to offer you whatever we can. Sometimes it's medical, emotional, so that you don't have to suffer. That's our philosophy,
absolutely.
you know.
Which is why, sorry.
Yeah, no, that just going along with what you were saying. So obviously, I'm going to support your choice to go, because, and I also feel sometimes people, and this is actually written in the Handbook of Thanatology, sometimes people don't realize that the end of life there are sometimes physical symptoms to manage. And in order to have the moments of sitting with mom and talking and having this beautiful experience you had, my observation is that sometimes you have to do some of the medical stuff first in order to get this lovely, but sad mother-daughter, time together.
I'm with you 100%. The first thing I say to my clients is hospice, hospice, hospice. Well, that's a whole nother discussion about when you talk about end of life,
Yeah.
but that to me, that's the only way to
Mm.
go. And yes, I mean, if someone's in terrible pain, what kind of meaningful conversation? First of all, I couldn't watch it as a daughter or as geriatric care manager. And yeah.
Yeah, absolutely. We don't want to see people suffer, of course, of course. And then, then you can have these moments together and these conversations. Yeah.
Yes. And all that said, I once worked with an aide. She was from Ghana, and we sat down with the wonderful hospice nurse and talked about the white box.
Yeah.
So, and I wasn't going to be there 24/7. This was with a client. And so we sat and we talked with her about it because she was there. She stayed overnight, so she was 24/7. She was there most of the days. So it was most likely that he would have died with her there. And in fact, he did. But so we went all through the white box and, we talked, and she didn't really ask any questions. So afterwards I said, Elizabeth, are you okay with this? And it became quite clear to me that she felt we were hastening his death.
Mhm. Yeah. Yeah.
So that became a huge issue. And I thought, oh, now what do we do?
Yeah.
So that took a lot and yeah, I'd love to hear your thoughts on this because that's been a problem.
Yeah, I mean, but first, I just want to say to anybody listening out there, so this must have been a private hire aid, right?
Yeah.
Because private hire aides are what we also call, you may have called FES, family employed subs. They
Yes.
can do anything the family would do, which is give medication. Aides from an agency can't give medication.
Right.
So I just want to say that. Yeah. And then the box, oh, like you said, every hospice patient in the country gets this white box. Some people or some places they call it emergency kit or care kit, but it is this kit, and it's for the main hospice symptoms. I always had my little spiel. I'd say pain, agitation, restlessness, constipation, diarrhea, and then I hate to use this term, but the death rattle, there's a little, right? And it's very easy to follow, right? You got a piece of paper and everything is color coordinated. So I hear you. I think, you had such an important job is to talk to Elizabeth or whoever it is and say, hey, do you feel comfortable? What are your thoughts? I think this is a big, I'm going to say barrier. And I think this is a big part of home hospice and of caring for people,
Yeah.
right?
Yeah.
That we use the term psychoeducation. I don't know if that's the term you would use also, right? And I agree with you. Am I hastening the person's death or not? Right. And this goes back to what we just said a few minutes ago. We believe people shouldn't have to suffer,
Right. And
right?
that's the bottom line.
Yeah.
Yes.
Yeah. So, that was also a lot of the kind of work that I would often have to do as a social worker. Um, yeah, educating people about, this just helps the person be comfortable, right?
Absolutely. And may I say, Carolyn, God bless the social work,
Uh,
especially the hospice social workers. I can't imagine doing my work without the hospice social workers and the nurses. I love hospice people altogether. But the social worker just, you guys are magic, pure magic. Just that same alchemy that I think a geriatric care manager needs, which is, it is magic. It's love, and it's sense of understanding and compassion, and I don't know what else.
I think, I think one of the things is that you have to marry compassion with like I said, there's this psychoeducation piece, and we want to make sure people are comfortable, but it's a balance, right? It's this like and I think it brings in autonomy or choices too. People are from different cultures, different, there's so many different pieces to that. Sometimes it could be a generation difference, or, so it's like, how do we balance all of these pieces? And different from a facility, I feel like so much is going on, right? When we're in the home, it's like, whoa, we're kind of juggling things in a little bit different way.
Yes. As opposed to, say, an ICU where
Mhm.
one of my beloved clients from the couple that I cared for ended up, only because when I did talk with him about end of life and death, he said, I want everything possible.
Wow.
So, and he was 89 with COPD and many, many, many multiple comorbidities. But he said that he wanted anything possible. So I respect that. So when he did, I think he coded, well, um, I did call 911, which, I is not would not be my choice, but that's what he wanted. And so he did end up in the ICU, and one of his sons of two did have time to get there. So there we were in the ICU, and the son is standing with, all the stuff. And the son looked so lost. The son, although he was in his 60s, looked completely lost. And I said, listen to me, you can request that they not keep these machines on. The doctor knows how to disengage the machines in a way that will not hurt your dad. This is up to you now. You can do this. So he was really grateful for that. And he was coming around to saying, yes, that's what I want to do. And his dad, in fact, died. So, but he was there and I was there. So that was good.
So that's a really tough one. My observation from working with clients, and I understand from being a human, is that I think it's when someone chooses hospice and dies naturally, I think it's very different than when someone goes to the hospital or has these interventions and then you have to remove them.
Yes.
That level, there's this extra level, I think is really hard on people.
Yes.
Yeah,
You
I don't, yeah,
actively have to do something. Yeah.
yeah, yeah. A lot of feelings in that. Wow.
A lot.
So we're kind of going, we're weaving things in, which is wonderful. Because I was going to ask you, define what a geriatric care manager does, but we have we've already started to do that.
We have done, but so I've been thinking about that. I think about it all the time, and I think, well, everybody practices differently, and the way I like to practice is as I say I like to make someone's life better, safer, sweeter, and more fun. That's
Mm,
my focus. I want people to have fun, and we do have fun. We laugh a lot. Um, I mean, it has to be the right combination. Obviously, I flex to whatever the person, whatever their gestalt is. But I'm thinking more about you asked me about this last case with this, and it was just about the most wonderful imaginable scenario. It was a couple and 5 blocks north, as I said. So again, that tension, I was there all the time. I didn't want to be out there all the time. They wanted me there all the time. I had to remind myself I wasn't their daughter. I had to remember to be the professional. I mean, I am, but that
mhm,
there's a blurring, as we discussed. Um, but so, and both of them had a great sense of humor. So, so I did things like the husband was very domineering, and
mhm,
both of them had a lot of comorbidities, and both of them clearly well, when I first met them, they clearly were in probably the last year of their life, but they lived for 4 more years with a lot of work and bringing in people to cook for them because they weren't eating. They were kind of scrounging around the kitchen, and they had the means,
Mhm.
and the sons were not resistant for their using their means, thank heavens, because that would have been a fight that I would have had to fight. But so we brought in someone to cook for them and look after their nutrition, and they used me quite a lot. So one of the things I did was, since he was so domineering, I said to him, okay, I'll call him Richard. I said, okay, Richard, Wednesdays are ladies' days. And that means you are not allowed to speak unless Ruthie lets you speak first.
Mm.
So
I like, yeah.
it didn't really fly, but it gave, I'm calling her Ruthie. It gave Ruthie a chance to say, hey, I'm in charge, very much in the drama therapy mode, by the by. Her enrolling as, someone with agency and in charge, and with a voice, despite his being very domineering. So we laughed a lot about that. And of course, he didn't ask permission to speak on Wednesdays, but it was a concept we introduced. So, that's just a teeny little thing, but
Yeah. I mean, so it's interesting because you obviously understood this pattern, this long-standing pattern of communication. I'm sure they'd been married, and you were and you were trying to work within it.
yes.
And I love that technique you used.
Well, another thing was, talking about end of life with clients is always tricky, because when do you introduce it? You have to sort of see where they are. Some people are completely in denial about death, even in their 80s.
Mhm.
Some people embrace, I don't have to tell you.
Yeah.
So with them, the first thing I needed to do was to earn their trust so that I could do the things I can do for them. And it took, with Richard, it was easy. With Ruthie, it took a few months. But then she loved me, and she trusted me 100%, which was great, because there were times when I really needed to intervene because her cognitive decline was
Yeah.
difficult, and that was rough. So with them, everything, they had such great senses of humor that we did laugh so much about things. So we started talking about, when I started talking about, I said, well, let's see, I'm trying to think how I want to go. And then Richard said, well, why don't we get a car and drive off the Statue of Liberty and all just like drive off the Statue of Liberty and all sink together. And I'm like, yeah. And who else would bring with us? And so it was just this great flight of fancy that the three of us had, and we were laughing, and it was great. So that kind of took the teeth out of it.
Wow. Okay, so you really had to kind of figure out how you were going to introduce this idea.
I did. And I think then it wasn't still very real to them.
Mhm.
And which is what we all struggle with as humans. We know we're going to die, obviously, but is it me? Is that real? It's tricky, and it doesn't matter how old you are.
Mhm.
Yeah.
Yeah, yeah. No, for sure. Do you help with paper like with healthcare proxy, or did you get 5 wishes or MOLST, or how do you?
We didn't have to do most, which was great. 5 wishes I didn't know about yet. Darn. I would have loved to hear Richard talk about his 5 wishes.
Mhm.
My goddess daughter, for example, says, no neon lighting, and I have to have my nails done, and there have to be dogs and carpets, and those are all written out with like stars on the paper and stuff. So
Wow.
yeah, which I love. That's my model for 5 wishes. But so no, we didn't have the 5 wishes. I'm sorry, I forgot the question.
Oh,
You were
just,
saying,
is there certain paperwork you
oh,
generally try to help people with?
oh, absolutely. It starts with the proxy, of course. The proxy, all the advanced directives. They weren't into any kind of video or any of that stuff. We didn't have to do a MOLST or a POLST. So it was pretty straightforward with them, and it has been with most of my other clients. Sometimes the lawyer will take care of it, oftentimes. And yeah.
Okay. Do you assist with funeral planning or bring it up to them or?
Yeah, that's another good question and a tricky one. I do. I absolutely, I must know what they want for their burial or for their cremation or whatever they choose. So I do help with the paperwork, absolutely, because when I speak to the funeral home, I have to know, obviously. And yeah. I
Mhm.
also involve the adult children if there are
Mhm.
any, so that they
Mhm.
know.
Absolutely.
Yeah.
Would you call it a family meeting or how do you kind of?
Yeah, that's a really good question. I do a family meeting. I tend not to make it strictly about death because
Yeah.
it freaks everybody out to start with. So we'll do a family gathering and have delicious food and talk. And then I'll have my agenda
Mhm.
and I'll say to them, hey, look, we know everybody dies and let's talk about this. This is after I've talked with the older adult
Mhm.
and made sure that they're not completely in 100% denial and that death frightens them or that they would be angry or upset with me or start to not trust me if I started talking about their death.
Mhm.
So just like I also come out of a disability care model, and it's the same thing. It's that slippery slope ideas that I don't want them to think that that's why I'm there. I'm not about their death. I'm about their life and their joy. And I also need to know their wishes.
Mhm. Yeah. Yeah. Well, I envy you a little bit, because when I was on hospice, we sometimes it was getting to the point where we really had to push these conversations, and we just, yeah, we had to. So yours sounds a little more fun.
Well, that's the idea, but I'm at a different stage than you are. I'm beginning.
Yeah, so I like that you had your drama therapy, and these other techniques sound, yeah.
Yeah.
So I was gonna ask you, any other, you had talked about this one, these clients. Were there any other clients or anything else you would want to share? Any other stories that you think might be helpful for people to hear, useful, informative?
Yes, absolutely. I was thinking about that, and there's one client who the adult children came to me, and she was in very bad shape. She
Mm.
had been living at home. She had stopped eating, and she presented as quite ill. Nobody knew why exactly. I only got to see her briefly. She didn't trust having me in there. She was very uneasy with me there. So I never want to push that. The last thing I want is for them to
Mm.
see me, come in with a clipboard. I don't use a clipboard, by the way, but I didn't want to be
Yeah,
one of those clipboard people.
yeah.
So I only got to see her a little bit, but from what I saw, she was 94 or so. So,
Mm.
it would be reasonable that she might be towards the end of her life. And from everything I saw and from my discussion with the nurse, she had a nurse practitioner who visited her. And of course, they gave me the permission to talk with her. And the practitioner and I both thought she was at the end of her life. And I said, let's get her to a doctor because I looked and I couldn't find a doctor visit. And I said, come on, let's make sure she sees a doctor. Well, she got to the doctor. It turns out she was on too many pain meds, too many and too much.
Wow.
She was way over medicated I didn't know what her issues were, and nobody was in a good position to really tell me clearly. So this doctor was terrific.
Oh,
And
wow.
and she said, let's stop this. I'm
Mhm.
sorry. She had had a fall and she'd hurt her back. And so, that can be so painful. So I didn't know what her
Mhm.
pain was. And, I'm not a doctor. So the doctor was terrific. And she said, let's DC this, let's,
Mhm.
um, fool this. Well, I have to tell you, Carolyn, it was like a
Mhm.
night and day. She came out of this, she started to eat. Now, I will add here that her adult children were so terrific and so present,
Mhm.
bringing her, delicious food to eat, which wasn't
Yeah.
contraindicated, of course.
Mhm.
She wasn't on any special diet. And the turnaround, really, I get verklempt, I could just cry when I think about this woman who I really thought was, at the end of her life. But no, she's still thriving now. And this doctor said, get rid of this, get rid of this. So I thought that was a really important case for people to know about, is that don't give up on people. And, let's get somebody in who really understands medically.
That's great. No, thank you. I think that's really important. I agree, and I love that you did that. And she was so lucky to get you, to find you. Her kid, I guess her kids found you, right?
Yes, actually they live in
Yeah.
my building. One of her son does, so that was easy.
Yeah.
But yeah, I
Yeah.
was really grateful. I mean, what a happy story to be able to tell.
Mhm.
Yeah, she's really enjoying her life.
Wow. So you have happy stories. You
I
have happy.
do.
And I'm gonna reframe though. I also think that it's very sad when people die, and you gave them a lot of happiness before. You had these funny stories. You had 4 years with that couple, and you said we laughed a lot, and so yes, I heard they eventually went on their way, but in the meantime, that there was still happiness in it, right?
There was happiness in it. That's right, Carolyn. And if someone's going to hire and pay for me, I want it to make their lives better and more, obviously it has to be safe. We
Mhm.
don't hang from the chandeliers, not yet. Um, but I like this one, Ruthie, who was frail, not her real name, who was frail. I got her grab bars to,
Oh,
again, they were of means. I got her grab bars to put all along. They had one of these old Upper West Side apartments with like a long railroad car space between the kitchen part and the bedroom part. And so I got her grab bars to put all along the way so that she could walk from one to the
wow.
other safely.
Mm.
And I got them from this wonderful place where you can get like the beautiful ceramics, so they're soft and
Mhm.
1/4 inch, not 1/2 inch, so she could grab on, easily and
Mm.
safely. And they were really pretty. They had artwork out in that hallway, so we pretended we were at the museum.
Oh, no.
We had fun. We always had fun.
I love that. One of the things that I talk about is that we have to work with everybody individually. And it feels like you've really embraced that. For this couple, it was pretending we're at the museum, or, with other, I'm sure it sounds like you really understand who you're working with as a human, and you're working with them in their individual way.
Absolutely. That's exactly what I do, Carolyn. And the way I start is I sit down and I say, tell me about yourself. And I want to be a therapeutic presence for them. That's my goal. And part to me of therapy is enjoying one's life
Yeah.
in the moment. And so before I'd read anything about doing a complete geriatric assessment, which is not what I do, that's what the physician does. But I mean, for doing an assessment of the client, and that was my instinct, to say, tell me about yourself, because to me, it's therapeutic, as you know, as a therapist, to listen and hear and bear witness and hear their life review, and everybody wants to tell you about themselves. So I love that part. And so that's when I get a sense of, oh, so I pick up on that and then I go from there. And it's not about me. I mean, yes, I love to have fun and I love to laugh, but if that's not them, then, clearly that's
Mhm.
not good.
Yeah, absolutely. Right. You have to meet the client where they're at. Right.
Yes.
Absolutely. You had mentioned sometimes geriatric care managers are also called aging life care managers.
Yes. Yes.
Did you want to mention something for a second about that,
Sure.
or?
Yes.
Yeah.
The organization for geriatric, well, I call myself a geriatric care manager. I'm from the old-fashioned world, but we rebranded ourselves as Aging Life Care people, um, because the idea of the word geriatric has kind of a negative connotation for some people. Um, And so, and the idea is, just as I said, is about living and we're aging. And so, yes, we rebranded ourselves as the Aging Life Care professionals. And so there is an association called the Aging Life Care Association, and it's wonderful. And you can find a Aging Life Care associate by zip code. It's a terrific resource, and it's a wonderful organization. And I highly recommend looking into that organization to find somebody or to learn a little bit more about what Aging Life Care Associates, geriatric care managers do. So it's under aginglifecare.org.
Right, right.
Yeah.
Yeah, thank you. I think that's really
Sure.
important.
Yeah.
And yeah, aginglifecare.org, right?
Yeah. Mhm.
And I want to add, I know I'm like end of life, but I want to open it up because it sounds like aging life care managers, you could hire someone at different maybe you need help with, is this right? Home care or
Yes.
yeah.
Or bill paying or
Mhm.
finances. Not everybody is able to do it or able to hire somebody. Aging life care associates can do the uh, whole panoply of things that people might have done for themselves in the past or might have had a spouse do, and the spouse has died and they don't know how to do it. So yes, Aging Life Care Associates specialize in all different skills. I personally am on the medical and kind of social side, but I know how to find people who can help with bill pay and finances. And then that's what we also do, is we bring in the professionals who do the things that we don't do professionally. Yeah.
Okay. So good. Thank you for really defining that. Because like I said, I know I'm very towards end of life, which is important. And we do talk about that, but it's a broader field. It sounds like there's, yeah, other services and people need those other services, right?
Absolutely. At all points in their lives. Yes.
Mhm.
Uh-huh.
Yeah. Okay. Well, thank you. I learned a lot. This was really wonderful.
It was great. Thank you so much for your wonderful questions and for wanting to hear from me. It's lovely.
Mm. Well, let me, ask you, is there anything you want to add, anything important to say? I do really want to direct people to your series of 13 columns. It's in Caring for the Ages is the name of the journal, right?
Yes, published by Elsevier.
And I'm going to put that in the podcast so people can see. And it's called A Daughter's Journal.
Yes. Yes.
Okay. Yeah, but I'm sorry, before I jump in, was there something else you wanted to add before we talk about that again?
No, I think we've really covered it. My philosophy is that whenever I'm working with someone, it's about enjoying their lives and making their lives better, whatever that involves.
Mhm.
And then
Yeah.
there's the whole family side, which we haven't talked about, but there's that.
When you say family side, like working with the adult children and trying to
The
balance.
children, for Richard and Ruthie, they were very isolated, and I whenever I would keep track of all the birthdays in the family, and we would have celebrations. And they had a wonderful apartment, and they hosted singing every Friday night, which I made sure they were both able to get to when they wanted to. I also made sure Ruthie could stay in her room if she didn't feel like facing it, which towards the end of her life she really didn't, but Richard wanted to, so we sorted that out. But yes, always the celebration. And I'd run around and get cakes and make a party like a New York party, not really a New York party, but
Mhm.
you know, candles and balloons and fun things and good food. I must say that my experience with older people, just like any people of any ages, they really enjoy good food if they are able to eat, have no restrictions. But I must say, once given the good food, it really helps people thrive. Drinking and eating, I always would tell my Ruthie when she was in hospital, I'd say, Ruthie, eating is life and drinking is life. And she was the best eater when she was in a hospital. It was just great.
Mhm.
So yeah, thriving like any age or stage in life.
Mhm. Yeah, enjoying those things that they enjoyed before. Yeah.
Yes, exactly.
Yeah. Do
And
you, oh, go ahead.
no, I was just going to say, that's really my philosophy, in addition to nothing about me without me, is that as we've noticed, as all of us, we all age, is we're like, wait a second, hey, I'm the same person. wait, I'm the same person as I was in my 20s, 30s, 40s. Wait. And that's exactly, no matter how they look
Mhm.
or ambulate or don't, they're the same person. So that's really important to remember.
So you bring up something really important, and I say this all the time, is that sometimes I'll read something and I'm like, it makes me feel uncomfortable because sometimes I feel like people think when someone, especially when they're end of life or they go on hospice, it's like, oh, the dying. And I'm like, well, the dying are, it's not life, dying, death. It's life, it's all combined. There's still that, like you said, there's still that person, even if they're on hospice or towards end of life, they're still a person, right?
Absolutely.
Um,
Yes.
yeah. So
Like you
when,
and
yeah.
me, just like you and me. And
Yeah.
so
Or
important.
and who they were before. I say, at end of life, if you, didn't get along with your daughter, then well, there's going to be things happening now. Or, if you loved dogs, then you're gonna, like it's all, combined. Like, I know I had a patient, she had this cat and it stayed with her like the entire time. We're like, oh, the cat's, that, yeah, didn't leave her.
Mhm.
But it's interesting what you say about age. I'm working with a client who is in her, I don't know, late 50s, let her hair go gray. And her dad um, was in the hospital, something happened, and they were trying to assess what was going on with dad, if it was a stroke or whatever. And they asked him, how old he was and what year he thought it was. And his, gray haired daughter is with him. And he thought it was like the 70s and he was like 35. And she's like, Dad, I'm like 55. And like, if you're 35, but like he went back to this time, right? You're still that same person,
You are. My 99-year-old mother-in-law, when asked how old she felt she was, she said 45. Oh, and if we have time, I just want to add one more thing. And
Yeah.
that is, in the beginning, you mentioned my passionate advocacy. And
Mhm.
one of my big things is a hospital when my client is in the hospital.
Mhm.
And I will march up and down that hospital corridor. I will make myself seen.
Yeah.
I find out the name of the nurses, the assistant, the CNAs, or that's what they are in Florida. But
Mhm.
whomever is on that hospital floor, I find out their name. I talk to them. I I make sure they know my client is a person. I one time kind of staged a intervention by getting my client off the geriatric floor in a hospital and onto the medicine floor. That's another story. But the point is, and I keep all the clinicians in touch with one another. So my client
Mhm.
who had COPD was in hospital for a heart issue. I got all of his heart people, his physio,
Mhm.
sorry, the electrical person and the interventional cardiologist and the regular all the cardiology people, his pulmonology person, his primary care practitioner. I got them all in an email thread, and I said, okay, look, here's today's update, and do you want to? So I always ask the clinicians to weigh in so that we don't make those stupid mistakes that
Mhm.
happen and can kill a person so easily. Yeah, so I'm big on that.
So really coordinating the care,
Yes.
that's wonderful. I think.
Keeping everybody
Yeah.
talking so the person down the line doesn't say, oh, but they shouldn't have done that. They said, no, we don't let that happen. We keep everybody in touch,
Mhm.
real time.
That's so important. That's so important. And I was from hospice. We work on an interdisciplinary team. So, I'm used to that. And it's really important, this interdisciplinary. And, even in hospice, our hospice docs will collaborate with the other doctors. But I hear
Yes.
what you're saying. I think a lot of medical institutions and doctors don't do that. They don't have an interdisciplinary approach, right?
No, and one person falls off the radar and could have helped by the pulmonologist saying, no, his oxygen, he shouldn't get anything higher than a 4 or,
Mhm.
whatever it is, or if his oxygen falls below, well, medical people should know that, but I mean, 88 but
Mhm.
no, I need all the disciplines talking to one another, all the different heart people and yeah,
Mhm. And
yeah.
I love what you said about the advocacy piece. And I know that that is really true nowadays. You have to have someone. And I know I've had so many adult, tends to be daughters, who say to me, what do people do who don't have someone who advocates for them? I'm here, with mom or dad, but, and it's true. What do people do when
Yeah.
they don't have someone, either an adult child or someone like you? It's really important. That you're there and advocating.
And unfortunately, they die, sadly.
Yeah.
Things happen and yeah, yeah.
Mhm. Yeah. So that's another important piece that you do that's really, that does really help people, right?
Yes. And I
Mhm.
just have to say, Richard, sorry, saw me in the hospital. He said to one of the nurses, he goes, she loves this stuff. And I mean, I love being there so that nothing happens to him, but I have to say it's exhausting being in the hospital, day in, day out, marching up and down the corridors and wondering when this doc is going to show up so I can have a little chat with her. And, but it was hilarious when he said, she loves this stuff. I do love taking care of him. Yes.
That's wonderful, though, from his perspective, he obviously really felt cared for. I can hear
Yeah.
that. That's amazing. Okay. Well, thank you again for your time. This is wonderful. I
Right.
really appreciate you taught me a lot. And like I said, I'm really Caring for the Ages is the journal. Is that right? What do you call it?
It's a
It's
publication.
a publication. It's a
Yeah.
publication. And A Daughter's Journal is the 13-part series. I think that a lot of people that would really resonate with them. And it was called The Loneliness of the Long Distance Caregiver.
Is the first one.
Okay.
First
Okay.
one. Yeah.
Yeah, again, I think that resonates with people, and I think there's so much in that is important to talk about.
Well, thank you, Carolyn. It's lovely to be asked, and I'm happy to talk about this. It's, my thing.
Mm. She loves this stuff. What did he say?
She loves this stuff. She loves it. Yeah.
Well, thank you again for your time and for being so thoughtful. And this was really important stuff. But like I said, I really appreciate it. And I learned a lot as well.
Thank you so much. And anyone should please feel free to get in touch with me if they like, and they can find me through LinkedIn. So yes, I'm happy to hear from anybody.
And I'm going to put the LinkedIn, that link will be in the post. If you go to this episode and you look in the post, you'll see it. So I'm going to put all this information in there.
Great. Thank you, Carolyn.
All right. Thank you so much for joining us on this episode of Thanatology Themes.
Thank you.
Thank you.